Response and Prevention Outreach, Angela Conover. Angela.
Good morning. Thanks, Greg. And good morning, everyone. Thank you for joining us. Today is Knockout Opioid Abuse Day in New Jersey. And as Greg mentioned, it's a day dedicated in our state to education and awareness of the opioid crisis. So I thank you for joining us today for this webinar, Knockout Opioid Abuse Day, How You Can Help Fight the Opiate Epidemic. Today's webinar is brought to you by the Partnership for a Drug for New Jersey and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General. And once again, we thank them for their partnership, support, and collaboration on this webinar, as well as the entire Knockout Abuse Day learning series that's happened all year long. So we're so pleased to have with us our featured speaker for today from the Centers for Disease Control and Prevention, Dr. Jamie Mells. Dr. Mells, as Greg mentioned, is a lieutenant commander in the U.S. Public Health Service Commissioned Corps and is the U.S. Public Health Service Overdose Data to Action Coordinator. He's a subject matter expert on prescription drug monitoring programs and evidence-based opioid prevention interventions. So we're so pleased and excited to hear from you today, Dr. Mells. I know that you have served as the lead scientist working with the Association of State and Territorial Health Officials, and you've helped states build preparedness to respond to the opioid crisis. I know you have a diverse background in biochemistry and biology, and you've completed your PhD from Emory University. So thank you again for being with us. And I am now going to turn the presentation over to you.
Thank you so much. And thank you again for having me here. This is such important work, and I'm so pleased to be able to speak to you today about the CDC initiatives to address the evolving drug overdose epidemic in the United States. See if my slide is going to work. All right. So our basic objectives today, of course, are to understand the opioid overdose epidemic and the rising polysubstance crisis. I'll present a large amount of data on that so that we have a good understanding of what we're actually dealing with on the ground. We'll also review the evidence-based practices for preventing prescription opioid misuse and illicit drug use. And I want to pause here and say that I will be using the word misuse and illicit drug use. We have moved away from the word abuse to just reduce stigmatization of these populations. Our agency is trying to be responsive to the feedback that we hear from the community. And so it's, as we hear examples, I'll try to use the word opioid misuse and specific use disorders as we move forward. And then we'll also review some surveillance and prevention strategies that communities can engage in right now to help prevent substance misuse. Is the internet stable still good? I got a message saying my internet was unstable for just a second.
You sound and look perfectly clear, so we're good. We're good to go.
Sounds good. So I want to first, of course, always introduce this graph. We show it at every CDC presentation, so I would be remiss if I didn't present this one to you. So opioids include both our natural, synthetic, and semi-synthetic chemicals, and they interact with the opioid receptors on our nerve cells in the body and brain. The goal of those opioids is to reduce the intensity of the pain signals and feelings of pain. This class of drugs includes our most commonly prescribed opioids, oxycodone and hydrocodone, but as well as the illegal drug heroin and the synthetic opioid fentanyl that can be obtained both legally and illegally. So from 1999 to 2019, we have lost nearly 500,000 people have died from an overdose involving an opioid, including prescription and illicit opioids. The rise in the opioid overdose deaths can be outlined in three distinct waves. The first wave began with the increase in prescribing of opioids, denoted by the turquoise line. In the 1990s, we started to see a significant increase in overdose deaths involving prescription overdoses. At that time, at the CDC, this started showing up, we classified these things as poisonings. And we would later on start to change the way we talked about opioid overdoses. And these involved prescription overdoses, and these were natural and semi-synthetic opioids and methadone. And they've been increasing since 1999. The second wave was a rapid increase in overdose deaths involving heroin. This is denoted on the slide by the royal blue line. This was attributed to both the expanded distribution mechanisms and substantial decrease in the cost of heroin within the illicit market. It became cheaper and our traffickers became better at being able to sell it. The third wave began in 2013 with a significant increase in deaths involving synthetic opioids denoted by the purple line, particularly those involving illicitly manufactured fentanyl. The market for illicitly manufactured fentanyl continues to change, and it can have both profound consequences in communities. And it can be found really anywhere in both heroin, counterfeit pills, and cocaine. Coincidentally, I began my work at the Injury Center in 2015, shortly after we started to see that rise in illicitly manufactured fentanyl. We had just started our first opioid prevention program in 2014 entitled Prevention for Drug Overdose, a boost for state prevention. And at that time, we were only funding 5 states, Kentucky, Oklahoma, Tennessee, Utah, and West Virginia. And I was hired initially to support the work of West Virginia. Fentanyl changed the game really quickly. It changed the urgency of this epidemic. Fentanyl is about 100 times more potent than morphine, and fentanyl analog carfentanil is estimated to be around 10,000 times more potent than morphine. As I'm about to show you in the next few data slides, we are dealing with multiple issues. We're dealing with an increased amount of overdose deaths involving this synthetic opioid, but we also have a growing polydrug problem that's starting to change the way we work on this epidemic. By the end of 2019, the US had lost over 495,000 of our fellow Americans to the opioid overdose epidemic. So I'm going to start with small studies and kind of broaden out as we go forward. So this first study involved CDC and analyzed drug overdose deaths during January 2019 to June 2019. We utilized data from 24 states, including DC. Now, this data is not nationally representative, but it does provide a pulse check of what we're seeing with the overdose epidemic. Couple of key points. Illicitly manufactured fentanyl, heroin, cocaine, and/or methamphetamine, and both alone and in combination were involved in 83.8% of our overdose deaths during January to June. And there was at least one potential opportunity for intervention. 67% of those identified of those deaths had an opportunity for intervention. And so as we start talking about this, I want you to keep that number in the back of your mind. As we consider prevention efforts, this data provides that first call to action of how our hospital systems and our first responders need to have a role and have a bigger role in how we handle this epidemic. The next slide is big, and we've got a lot of data here, so I want us to go through this a little bit slower. As we began to look at the data around opioid overdose deaths, it became clear that the opioids were nested in a broadening polydrug crisis, partially driven by stimulants, such as methamphetamine, and to a smaller extent, cocaine. This slide is based on the analysis that was conducted using the drug overdose deaths identified through our National Vital Statistics System. We use multiple cause of death mortality files and ICD-10 codes to identify these deaths. A few caveats before we actually dive into the data. States with inadequate drug specificity reporting and that had too few deaths to calculate stable estimates or to meet the confidentiality requirements were excluded from the state level analysis. I want to orient you to the slide, and hopefully you can see my pointer as we go through. What you're seeing on this slide is on the y-axis, we have deaths per 100,000, and the x-axis denotes the year. We've divided the drug classes into the following groups. We have prescription opioids, heroin, cocaine, and psychostimulants with abuse potential. For this talk today, when we talk about abuse potential, we're really referring to methamphetamines for the most part. The first graph shows that deaths that resulted from the co-involvement of synthetic opioids. And so what we're seeing here is that for each drug class, there was a co-involvement of, or for lack of a better word, a contamination with synthetic opioids. What you see is we saw a pronounced increase in deaths related starting in 2013. The second graph shows deaths without the co-involvement. of an opioid and a synthetic opioid. And what you see here is, for the most part, with the exception of psychostimulants, you see a downward trend. So what you're seeing, the take-home message for this is that in 2019, we had a total of 70,630 deaths that occurred in the US, and 49,860 of those deaths involved in opioids. From 2013 to 2019, the age-adjusted rate of deaths involving synthetic opioids other than methadone increased 1,040%. And for psychostimulants increased 317%. And finally, during 2018 to 2019, the largest relative increase in synthetic opioid death rates occurred in the West, and the largest relative increase in psychostimulant death rates occurred in the Northeast. Now, as we move from looking at deaths to actual non-fatal overdoses, we will begin to see some overarching themes. This figure includes data from 42 states, including DC, and it's data that's from our syndromic surveillance data system, commonly referred to as our DOSE system. And New Jersey's data is also included in this. The data shows that on the far y-axis, you see the total ED visits, and this is for our pink bar slides, our pink bars on the slide. And on the far y-axis, you'll see our overdose visits. What you'll see is that the ED visits began declining in January of 2020, reaching its lowest point in April 2020. Look at the pink bars to see that change. This coincided with the national shutdown that occurred during the initial months of COVID-19. Starting in May 2020, the total ED visits started to rebound, but they were still lower than the prior months. And then also, if you look from March through September of 2020, compared to the previous time period, there were a higher number of suspected overdose ED visits for all drugs. And all drugs is represented by the purple line. The opioids is represented by the turquoise line, and heroin is represented by the dark blue line as you're orienting yourself to the slide. You can tell that there were different peaks depending on the substance. The number of suspected all-drug opioid-involved overdoses was highest in July 2020 and gradually declined during the following months, with numbers still higher in September 2020 than in March 2020. The numbers of suspected heroin and stimulant-involved overdoses were highest in May of 2020 and again gradually declined during the following months. What's concerning about this data is that during COVID-19, our emergency departments, which are really the best equipped to deal with overdoses, were less utilized. And so as we begin to talk about life during COVID and after COVID, we really also need to make sure that we are including our communities and how they're going to work on this issue. And I want you to keep that in mind, that our first responders are also going to be another critical piece of the in this puzzle as we start to talk about prevention efforts and their role in this overdose epidemic. I've shown you a lot of data, so I wanted to have a summary slide, so in case it was overwhelming, that you could see it all in one place, and let's make some and have some overarching talking points around that. So utilizing the data that I've shown in the previous slides from two of our CDC Sentinel surveillance systems, we can now identify some missed opportunities for intervention. In August of 2020, as I previously mentioned, we released an MMWR using data from 29 CDC-funded states showing that non-fatal drug overdoses involving opioids, cocaine, and methamphetamines increased between 2018 and 2019, and polydrug overdoses co-involving opioids and meth. In September, we published a vital sign, that a report on all drug overdoses from 28 states, including DC, and it showed that illicitly manufactured fentanyl and its analogs, as well as heroin, cocaine, and/or methamphetamine, were involved in nearly 85% of our overdose deaths from January to June of 2019. In short, the illicit drug supply is a key driver of our current epidemic. And among those key findings, we found that more than 3 out of 5 overdose deaths involved at least one potential opportunity to link a person to care. or have life-saving action like administering naloxone when the overdose occurred. COVID-19. To drive the hammer home, I want to show you the provisional data on drug overdose deaths during COVID-19. It really does paint a grim picture. This graphic shown on the left was adapted from a version that we published in our December 2020 Health Alert. It showed that the drug overdose epidemic appears to have worsened significantly during COVID-19. And if you look at each drug class, there are some differences, but we did see an increase overall. This data is with the updated data, provisional data from CDC's National Center for Health Statistics was released in July 2021, and it indicates that there was an estimated 93,331 drug overdose deaths in the US during 2020. I'm showing you a lot of national data, and national data is great, but I know you're sitting there thinking, what about New Jersey? What does our numbers look like? And so I want to show you some data that was reported from New Jersey's health department to what we call our summary of unintentional drug overdose death system, or SUDRS for short. And it indicates that New Jersey is experiencing many of the same trends that we discussed around the national data. Now, this slide is very busy, and my intent is not for you to read all of the data reported from the state health department, but I would like to point out a few key data points for your consideration. I also want to caveat this slide and acknowledge, as I just previously said, that this data is up to 2019, so it doesn't include 2020 and 2021. So as we previously mentioned, COVID has changed what we're seeing on the ground. And so this data may not actually reflect what the COVID environment has done to your state over the last year and a half. Before we dive in, I want to say that New Jersey has a higher age-adjusted drug overdose rate than the national average. The national average is 21.6, and New Jersey's rate is 31.7. So this is a pressing issue here. The age-adjusted opioid overdose rate is also higher than the national rate. Our national rate is 15.5, and New Jersey's opioid overdose rate is 28.4 as of 2019. As we look at areas to strengthen, please consider the following. I've put a box on the screen that 63% of deaths occurred in the decedent's home. So as we think about prevention in the next coming slides, naloxone distribution and community training have to be part of our game plan. 33% of the decedents had at least one potential opportunity for linkage to care prior to death, or implementation, again, of life-saving action at the time of overdose. So this gives us an opportunity to also think not only about naloxone distribution, but as first responders respond, and then what happens to them after they are revived, what happens to that person? Are we able to link them to care? And then polydrug use is a major issue in New Jersey, with over 63% of deaths having multiple drug classes present. Over half of the overdose deaths in 2019 in New Jersey could be linked or had illicitly manufactured fentanyl in the person's system. And so that lets you know that, like we've seen nationally, we have a polydrug system issue here in New Jersey, and illicitly manufactured fentanyl is a major player in these deaths. One area of good news that I would like to talk about is that the opioid prescribing rate for 2019 was lower than the national average. The national average is 46.7, and New Jersey is at 34.8 per 100. So there is some places where we have made some significant changes in New Jersey. And so that's really promising. And please continue. I know we have a lot of prescribers here, so we thank you for the work that you're doing to both attend to your patients and make sure they're getting the best care, but also doing it in a safe way that hopefully reduces overdoses related to prescription. At the outset of this epidemic, those most impacted were white rural males between the ages of 25 and 54. But now it's an everybody problem. What we've seen from 2015 to 2018 is that the opioid overdose death rates increased for both sexes and persons aged 25 years and older, all races and ethnicities, and all levels of urbanization. In this time, death rates increased amongst males to 47%, among African Americans, 25%. From persons aged 35 to 44 years old, it increased to 51%. And it affects both large fringe metro and large central metro areas. To put this in context, in 2019, as I said before, we've lost almost 50,000 Americans in 2019. And that's almost double the number that we lost in 2013 and almost 6 times the number of deaths in 2000. But it's important to also remember that this epidemic impact stretches far beyond the lives lost and of those persons living with addiction. We're seeing an increasing number of babies being born with neonatal abstinence syndrome because of drug exposure, such as opioids during pregnancy. These babies experience drug withdrawals after birth, including symptoms like tremors, seizures, and difficulty breathing. The increase in the use of illicit drugs is also sparking dangerous outbreaks of hepatitis and HIV infections among persons who inject drugs. Sharing needles, syringes, and other injection equipment puts people who inject drugs at a high risk for acquiring hepatitis, HIV, and other infections. The bottom line is that the epidemic impacts not only those people who are lost to the epidemic, but the families that are left behind. So how do we get here? I want you to think back to that first graph of the 3 waves. The first 3 points were really around prescription. Pain being designated as a 5th vital sign was a major driver. There was a misrepresentation of the addictive potential of prescription opioids. And then there was aggressive marketing of prescription opioids to clinicians. We also had some bad actors, some clinicians who ran pill mills that profited from overprescribing. When we moved to the heroin wave, we saw sophisticated actions of drug traffickers opening both new heroin markets. And then as the rise of fentanyl, we saw the potency and ease of making of fentanyl, plus the ease with trafficking and profiteering of illicit fentanyl and the fentanyl analogs really drive those numbers sky high. Finally, what we're dealing with now on the ground is really the mixing and co-use of illicit fentanyl with other drugs, especially cocaine and methamphetamine. So I hope at this point I've convinced you that the crisis is very real and that it's a pressing issue. I'd like to pivot now and tell you more about what CDC is doing to help combat this epidemic. Our North Star is to prevent overdose deaths. All our work is captured in 5 domains represented here on this slide. And I'll use the rest of my time to give you examples and illustrations of work underway with respect to coordinating surveillance and research, to building state, local, and tribal capacity for prevention, supporting providers and health systems and payers, and partnering with public safety, and then finally empowering consumers to make better choices or safer choices. Our largest investment in overdose prevention is our opioid prevention program, Overdose Data to Action. It was built upon 3 previously funded programs. So we always like to tell our audience is that CDC really is into using evidence-based practices. And so this program that we currently fund is based upon all the information and lessons learned from our previous 3 large programs. And that included our Prevention for States program, our Data-Driven Prevention Initiative, and our Enhanced State Opioid Overdose Surveillance Program. We've combined all of the work from those 3 programs and integrated it into one funding announcement. The purpose, of course, was to streamline reporting and staffing and budgets and create a seamless integration of surveillance programs. As the OD2A coordinator, my job is to help recipients use actionable surveillance data to drive and tailor their prevention strategies to what they're seeing on the ground. Our Overdose Data Action Program has several components. For our state-funded recipients, they are required to have a morbidity component, a mortality component, an innovation project, but they are also supposed to work on expanding and improving our prescription drug monitoring programs, improving state and local integration, linkage to care, providers, and health systems. Those are all required as part of the Overdose Data to Action program. They can also choose to do strategies within the public safety realm, empowering individuals, and they can also innovate within their prevention programs. We currently fund 48 states, 2 territories, and 16 large counties. In addition to our large programmatic work, one of the needs that we identified early in this work was the need to document or summarize what we know works in communities. So we call this our Purple Book. The team developed an evidence-based menu and published a summary report on the 10 best practices. And these practices include detailed explanations of what communities can do right now to help reduce overdoses in their area. Couple of ones that I want to definitely point out are the targeted naloxone distribution, and we've talked about why that's important with the data. 911 Good Samaritan laws, syringe service programs, but also include treatment strategies like using medication for opioid use disorder in both the criminal justice setting, but also upon release. In emergency departments, buprenorphine initiation is also something that we've seen has a large amount of evidence that shows it's both effective and works long term. Academic detailing is important because it involves working with those high risk prescribers as well as fentanyl toxicology screening to monitor the drug supply. All of these have been shown to be effective and things that communities can put funds into and put their people power into and really make a difference in their numbers. And I've put the website here at the bottom for your reference. We're also in the process of updating our CDC opioid prescribing guidelines. The intended audience, of course, is recommendations for clinicians who are prescribing opioids for outpatients. And these are patients 18 and older, acute less than 1 month, or subacute a duration of 1 to 3 months. And of course, the chronic duration of greater than 3 months for pain. This should be outside of sickle cell disease related pain management, outside of cancer pain management or palliative care or end of life care. Oops, sorry, did I go? Sorry, let me scroll back. All right. Few more comments on the opioid prescribing guidelines. The update was based on input from patients, caregivers, clinicians, and the public, as well as new evidence. The updated guideline draft includes expanded guidance on acute and subacute pain, updated information on the benefits and risk of non-pharmacologic, non-opioid pharmacologic, and opioid therapies for chronic pain. And finally, we have expanded guidance on opioid tapering and on opioid management for patients already receiving opioids on long-term care. I wanted to note a few prevention programs in my last few minutes of the talk and these prevention programs have a lot of solid evidence on their effectiveness. And so one of the programs that we support in OD2A is our prescription drug monitoring programs. The goal of our prescription drug monitoring programs is to enhance the timeliness and comprehensiveness of the data, but also incentivize healthcare providers to use the PDMP. And actively manage it as part of their healthcare process. We want the PDMP data to be integrated into clinical workflow and provide clinician decision support for clinicians. The goal of incorporating clinical decision tools in the workflow is so that clinicians can do it as part of their treatment and care of their patients, and they don't have to go outside of the portal to look at this data. We also want you to leverage our PDMPs for public health surveillance. One of the new programs that has developed because of the overdose epidemic is we have a new partnerships with our public safety partners. This partnership was created specifically to help local communities with reducing overdoses and overdose deaths. The goal is simple. We're sharing timely data between public health and public safety. We collect data very differently, but we have data that will help a community make a better and more holistic decisions if they had both sets of data. The Office of National Drug Control Policy had as the goal of placing a public health analyst and drug intelligence officer in every stage. And I'm happy to report As of July 2021, we now have a DIO and a PHA in all 50 states. And so this should help dramatically improve the coordination between our public health and public safety partners. The other major public safety partner that we've been working with is the Bureau of Justice Assistance. We have a rural response program to help in those rural areas that are experiencing overdoses that lack the same resources that our metro areas have. We have an overdose detection mapping application, and that's for we're piloting states and tribes and understanding the drug supply and mapping it, and then having responses developed as part of that. We're building bridges between jails and community-based treatment for opioid use disorder. This is a very vulnerable population, so this work is critically important to helping drive down the overall numbers in both nationally and here in New Jersey. And then harm reduction training and education for law enforcement. We know that we can't do this alone, and so our work with our law enforcement partners is really important to achieving these goals. And then we have overdose fatality review projects, and New Jersey has a robust program that they're starting through our Overdose Data Action Program. These are critically important because it helps us understand the changing nature. You know, one of the things that these reviews help us understand is how people are using, how people are dying, their linkages to care, or their lack of linkages to care. And so those partnerships and those reviews experiencing a certain
Dr.
surge.
Mills, I think we lost you just for a minute there.
Oh.
So if you could just, yeah, I'm not sure if you
sorry.
could just go back to the end of that slide. Your screen went black for a moment.
Oh, okay. Did you hear Bureau of Justice Assistance, BJ?
We heard part of it. So
Okay.
you could just maybe skip to the harm reduction training end.
We all have been here for a year and a half, so I hope you all will extend grace to each other. And I hope I'll cover this real quickly again. So with BJA, we have a rural program for those communities that don't necessarily have the same resources as our metro areas. We have an overdose detection mapping project, and that's really to look at the illicit supply and help communities respond more quickly to what they're seeing on the ground. We have a building bridges between jails and community-based treatment for opioid use disorder. And this is a critical population. A lot of the large amount of data that's coming out is that a large portion of states' deaths come from this population. So linking them to care, treatment in jails is a good way to bring down your overall numbers. Harm reduction training and education for law enforcement is critically important because it allows law enforcement to more fully engage, and they're sometimes the first responders, the first people on the scene. So having them well-versed in harm reduction is an important component to any prevention work. And then our overdose fatality reviews does two things. It helps us understand how people are using now. It also helps us understand if there are differences in how they're linking to care, or if we're missing those opportunities for linkage to care. So the overdose fatality projects are critically important for the prevention work, and we do that work both through BJA and through the Overdose Data Action Program. As I mentioned, the Opioid Rapid Response Program is really designed for states that are experiencing a sudden surge and overdoses. We hope to build capacity for them to both understand that surge and deploy resources. And so we work in close partnership with our law enforcement and public safety partners. But if we close down a large clinic, we want to make sure that those patients are not falling through the gaps and potentially overdosing as a result of a large clinic closure that has been acting outside of the prescribing norms. And so the Opioid Rapid Response Program really is aimed and designed to help states quickly respond to those kinds of changes. RX campaign, I am super happy to announce that it is an Emmy award-winning campaign. One of the things that I want to, if you get nothing else from this too, and you're trying to raise awareness in your communities, we have a suite of resources that you can download, including these ads that you can run in your local communities. They're diverse. They talk about they have different groups that they're targeted for, both people of color, tribal persons suffering with misuse and addiction, but there are also a lot of great stories about hope and recovery. And so it is a great campaign, and we hope that if you're looking for resources that you will visit cdc.gov to look for the RX awareness campaign. We have ads and posters and slides and really anything that a community could need to start raising awareness. You can start with the CDC and download those things. And we have SMEs available to help you tailor those to what you need in your community. And finally, what about the youth? I always get that question. So we have 700 drug-free communities that are really aimed at preventing and reducing substance use among youth 18 and younger. And so we now support 700 community coalitions across the country aimed at really helping those youth stop substance use or not start substance use. And so we also have that partnership with CATCA, and it's an amazing partnership because it really gives our communities the ability to really affect the people that they love in their local areas. And so the drug-free communities has been a great addition to us that we just started a year and a half ago. So that's a new thing that has come to CDC that was with SAMHSA that's now migrated over to us, and we're happy and looking forward to expanding those programs. And finally, this is my last slide. This graphic outlines the coordinated activities that need to really take place in communities across sectors. For example, local health departments can use emergency department data to alert communities about surges and overdoses. Or emergency departments can provide naloxone to high-risk patients to prevent future overdoses and/or link these patients to mental health and substance use treatment providers. Our public safety and law enforcement can identify changes in the illicit drug supply in an area and help quickly mobilize local partners. And finally, community-based organizations really do represent the best opportunity at mobilizing a community in response to those that are most at risk. They're the most likely to be most effective in implementing harm reduction services that really can drive down your numbers. A coordinated response plan is key. CDC is funding programs through a variety of different mechanisms. And in New Jersey, for instance, we have helped New Jersey implement the county naloxone dashboard that provide near real-time data for local communities. You can expect CDC to do more to help facilitate these prevention, preparedness, and response activities moving forward. Finally, where do we go from here? We're going to continue to increase our support for harm reduction and expand the provision of use of naloxone and overdose prevention education. We want to expand access and provision of treatment for substance use disorder. That's a place we all recognize we need to do more. We need to intervene early with individuals at the highest risk for overdose. And we need to improve our detection of overdose outbreaks due to fentanyl and fentanyl analogs. And also, as we look at polydrugs, we need to make sure that we're able to then not only identify that, but disseminate that information to those communities that are impacted by those changes. This gives you really a snapshot of all the places that we're looking for future and further investments. We're gonna, of course, work on the CDC opioid guidelines. We want to scale up our public health and safety team approach for collaboration. We're gonna, again, look for better ways to mobilize and educate. Mobile outreach seems to be a place that we're really seeing some good evidence of effectiveness. And so that may be a place that we're going to also invest future dollars in. But this is where we call it a brainstorm, because we really are always looking for evidence-based practices that are showing a drop in the numbers. And so this will be a place that we continue. These are some of the places that we're starting to see that evidence. And so as that evidence builds, we will also increase our investment in those areas moving forward. We want to learn from the past, of course, and then, of course, think about the future. So with that, I will take any questions.
Thanks so much, Dr. Miles. I think that was a really informative presentation, but right off the top, I want to congratulate you on your Emmy, because that's exciting.
I didn't do it. I wish I could say my name was on it, but no. We have a whole branch that does nothing but comms.
I do want to also let all of our attendees know that if you go to the Opioid Abuse Day website, knockoutday.drugfreenj.org. There's also a toolkit with a number of prevention messages on there that you can use, as well as using the CDC's campaign to get a message out in the community. And if you share them on social media, use the hashtag Knockout Day or Knockout Opioid Abuse Day. So I just wanted to put that out there as well. I think it's so important that we have messaging and events like this, obviously. But as you know, our here in New Jersey, October 6th is Knockout Opioid Abuse Day, and you've talked a lot about different strategies, but what can days like this do, and what can those in attendance do to really help address the opioid crisis?
So the days like this are amazing, and quite honestly, like your attendance numbers are fantastic, because it really then shows a commitment from both your healthcare, public health, and law enforcement and public safety that you are committed to the product, the program. And one of the places that these kinds of days do is really link people to these other groups, particularly between public safety and public health. We really do need to continue to have that exposure and have those connections. And so days like this really give us a call to action to share data, but also think about what we're doing and see if there's some best examples that we can take from others. I'm always a borrow what's working kind of guy. So these kinds of days really showcase what's working so we can borrow, and not have to reinvent the wheel. So I really appreciate being invited to come speak with you guys.
And we're so pleased to have you. We have a lot of questions that have come in the chat. I know some of them we've been able to address locally from New Jersey regarding the prescription drug monitoring program and other questions such as that. But can you talk about what is being done to address this crisis in communities of color, outreach programs, PSAs? I know you talked a little bit about that on the slide about the campaign, but is there anything you can add?
Sure, and that's a great question. What we have seen is communities of color have had a significant rise over the last 3 to 4 years. And so one of the things that we're doing is working both with, we started funding both pilot programs that target both faith-based organizations, trying to build trusted champions in communities is another place that our drug-free communities are also working with. And then our PSAs, of course, have diversified in terms of our choices of what you can use in different communities. It is a growing problem. So it is something that we are trying to build health equity into a lot of our new language, so that we are making sure that we are addressing these different communities with that health equity lens in our approach.
All right, that's good. And so can you talk a little bit about the latest treatment options and medically assisted treatment and the CDC's support or comments on that?
Sure, and here's what I will say is that ED initiation of buprenorphine, medically assisted treatment still remain our really go-tos and Suboxone have really shown to be effective. I think what we're now grappling with is this multi-drug issue. So if a person is overdosing that has been thought they were using cocaine solely that was laced with fentanyl and they overdose, it's a different issue. And so how we treat them is something that we're working with our state health departments to figure out the best programs. Do we put them in an opioid only? Because if they're thinking they're using opioids, that's one of the places where fentanyl test strips have now become part of our harm reduction strategy. So one of the things that we do know is helping those persons who use drugs, if we can get them to change, having those first distributed as part of the harm reduction. So in a non-judgmental way, some like test your drug supply. That way you know what you're taking. And really talking about harm reduction strategies as like do not use alone. Always make sure your buddy has naloxone, so that way we also reduce those deaths. Those are some of the new things that we're trying to kind of lean forward in, because we are having to recognize those harm reduction strategies are showing promise. It is tricky though, of course, in terms of the political landscape of what communities feel comfortable with. So we want you to also, as you think about harm reduction strategies, think about the evidence. Is this something that you can do? But also, what can you get really incorporated in your community, given your local, what the local community feels like they can, I guess, tolerate or risk, the risk associated with that. So we're trying to provide a lot of evidence and a lot of information on what's working. And so that's part of what we're doing, is trying to really start to clarify the things that we are seeing significant reductions in overdoses if you employ these, strategies 1, 2, or 3, and moving forward.
Oh, great. That's one of the questions that we had. How do we, what's any suggestions on getting naloxone or other harm reduction techniques out into the community?
Yes, and New Jersey has started doing a lot of that. I think we have, through the SAMHSA STAR grant, there is the ability to purchase naloxone. One of the things that we've seen the most effective is when naloxone is distributed not only through our pharmacies, so if you pick up an opioid, you get naloxone, but also through our harm reduction communities. And so having them out as coalitions and being able to track that distribution where you get some naloxone, and then when you come back, you bring back that naloxone and we give you some more. And so that way we're able to track where it's being used. We can see that showing an effect and the decrease in EMS numbers going out. EMS is another place. Law prevention is also another place where anytime we're interacting and are responding to an overdose, we have an opportunity to link them to care and also provide naloxone as a way to help prevent the next overdose.
No, that's great. And so I think we're going to just pivot a bit and ask if you could just we have some questions about how to identify if someone has an issue, if there's some tips on that. And can you give some examples on how to support someone who is a substance user or their families in a obviously a non-judgmental way?
Right. And so how to identify? That can be varied. Identifying substance use disorder really is at that family level. So one of the things that New Jersey, and I'm going to speak kind of holistically with the public health providers community, is really educating community members to understand that opioids really are not a class issue. It's not a race issue. Anyone can be affected. And so what you want to see, or what you want to be looking for as you expose the community, I think we always tend to put this people who use or misuse drugs into a category of what we think they look like, and what we've seen by the data is that it is vastly different. It really is every socioeconomic status. So one of the things that you can do first is making sure that your community understands it's everyone. It is really could be from anyone. The next thing is making sure that you have harm reduction places where people who are using drugs can seek help, because having those peer-to-peer navigators in those harm reduction places really then provides a safe place for people to talk to someone who's been there, who's dealing with this, who has done recovery. I think those are good examples. Second part of your question, I wanted to also, one of the things that we have seen really effective is opioid response teams or overdose response teams. So after someone is OD'd or had an overdose, we have a peer-to-peer navigator, social worker, sometimes law enforcement, sometimes public safety, but many times just social worker, nurse practitioner, that go back out and are able to provide some naloxone to the community, have an opportunity to see if that person wants to be linked to care. Those have really shown to reduce recidivism in a really profound way. We've got a ton of pilots going around. And so what it is, those have been shown to reduce overdoses, and so that's another way to provide support to families. They can be having that kind of staffing, particularly in some of your urban areas. It does require having more than one team, right? You'd have to in different shifts. So that can be a staffing issue, and those are not necessarily always inexpensive programs, but they have been shown to be highly effective and used. And rural areas, we've seen it have gangbuster effects. So something to consider depending on where you are in New Jersey.
Yeah, and we're really lucky in New Jersey because we have a lot of peer recovery support programs, I believe, all across the state in each county. And also, I know the Office of the Attorney General funds a number of, and there are also other Hope One vehicles, which are mobile units that go across the counties, particularly in the rural areas, like you said, distributing the test strips, distributing or doing the naloxone training, providing access, information on how to access treatment and recovery services. So really fortunate. And also, just to add to something that you said earlier regarding collaboration, you'll see on your screen we have a number of partners who collaborate on Knockout Opioid Abuse Day. But we're really fortunate for the collaborators that we have had on all of our projects. I think we work really well together in New Jersey, and so obviously there's always room for improvement and more people to come to the table, and also to get that national perspective that you provided today. But we have been making efforts, and just want to just acknowledge everyone who has come to the table to make those efforts to work together, because I think what you said earlier, when you're able to share data and share information and share strategies, really you come to a better place in being able to address the issue. I just want to mention that the evaluation is now launching. So if anyone could take a moment and complete that, we'd appreciate it. One other thing, Dr. Mills, I know you touched briefly on the CDC prescribing guidelines. So we're really excited about those. I know we have a number of prescribers on today and pharmacists, people looking for additional information on that. So really excited to see what those look like here in New Jersey. We have some pretty good laws in terms of making sure that people are notified at the time an opioid is prescribed of the potential for dependency and addiction to that opioid. So that's a really, we started that here in New Jersey, and I think 18 states have copied that, and that kind of goes into some of the points in the guidelines. There's a pill limit and obviously a prescription drug monitoring program. So for all of our attendees, if you're not aware of that, please definitely check out our website, drugfreenj.org, or knockout j.drugfreenj.org, or visit the Attorney General's website. It's pretty comprehensive on all of that information. Dr. Mills, I just want to give you an opportunity if there's any last comments before we wrap up.
I have to say something about naloxone because I'm a naloxone trainer. If naloxone, we always say, especially if you use, the nasal one, it is easy to teach communities. I say that you can teach all the way down to, a third grader how to, because if you can use Afrin or a nasal decongestant, you can use naloxone. So if you haven't done naloxone training, it is available multiple places. It's the easiest way to really impact the community by getting naloxone into the hands of not only the persons maybe using drugs, but also opioids, but also their family members. And it's easy to teach. A third grader can do it comfortably, and it really can save someone's life. So if you haven't done those in your community, I would strongly urge you to consider that, because it really is been shown to be an amazing first step and reducing your numbers.
No, thank you. I think that's a great point to leave on, that we all can do something. We all have some role, and that's really is the message of Knockout Opioid Abuse Day here in our state. Again, thank you to our partners on the learning series, the New Jersey Office of the Attorney General, NJ Cares, and our partners and collaborators for Knockout Opioid Abuse Day as well, which are the Governor's Council on Alcoholism and Drug Abuse, New Jersey Department of Human Services, and the Community Coalition for a Safe and Healthy Moors, who have all been hand in hand, as well as with NJ Cares, in helping us and get this message out. Thank you again to all of our attendees. And Dr. Mills, we really appreciate the time that you took today. And I know leading into this, all the prep work, your presentation was so on point for what we wanted the message to be today. And we really appreciate the information. I think it's going to help all of us make better decisions and really help address that opioid crisis in the state. So thank you again, and have a good day, everyone. Be well.